Hi, my topic is comprehensive molecular characterization of papillary renal cell carcinoma, and my name is Raí Ponce. The first definition. Kidney cancer or renal cell carcinoma is not a single disease but is made up various types of cancer that are characterized by different genetic drivers. Each type has a distinct histologic features and distinct clinical course of response to therapy. Papillary renal cell carcinoma, which account for 15 to 20 percent of kidney cancer, is a heterogeneous disease with histologic subtypes and variation in both disease progression and patient outcomes.
Cell carcinoma is the second most common subtype of renal cell carcinoma. The most common is clear cell renal cell carcinoma. Papillary carcinoma usually shows predominantly papillary architecture, and it frequently has well-formed fibrous capsule. In this part of the picture, we can see residual renal parenchyma. Here we have perirenal adipose tissue and this large papillary mass. This is papillary renal cell carcinoma. Here we have the fibrous capsule of the tumor, which is usually lined by the epithelial cells that resemble the tumor cells. The fibrous capsule in this example is not very prominent. It is usually thicker. Here we can see the papillary pattern of growth where the tumor forms. These papillary structures lined by neoplastic cells with a central fibrovascular course. It is not uncommon to see other types of growth. Here we have an example of glomeruloid structures that resembles normal renal corpuscles. Here we have a small area of solid growth, and here we have an example of tubular or acinar type of growth with a few foci that slightly resembles small glomerular structures. A very useful sign of papillary renal cell carcinoma is the focal accumulation of these foamy macrophages, also here and here. All right, papillary carcinoma. Thanks for watching.
Application in medicine. We performed an interactive genomic analysis of 161 papillary renal cell carcinoma tumors to provide molecular insights into tumor classification, inform clinical recommendations, and suggest paths to the development of mechanically based therapies.
To better understand papillary RCC, what you have to understand is the big picture. And so overall, out of 100 renal cell carcinoma, 80 will be clear cell. We're not talking about this one, we're talking about the 20 left. And 15 of these 20 left will likely to be what we call papillary renal cell carcinoma. And it's based on the morphology, how it looks like when you look at the tumor with a microscope. And within this family of papillary renal cell carcinoma, there are usually two entities that are what we call the type 1, which tend to be rather smaller tumors, more localized to the kidney, or what we call the type 2, that can evolve more rapidly to metastatic disease. So these are a kind of renal carcinoma. There is no specific risk factor for this subtype, so we stay on the field of age 60 with known risk factors as hypertension or obesity, overweight. The thing is, we do also know that there are some inherited syndrome that does exist, and we can have that with papillary renal cell carcinoma. So there is some inherited syndrome with that kind of tumor. But what we do know is that for the first part of these papillary renal cell carcinoma, which are the type 1s, It's very likely that MET, it's a gene that codes for a protein that is on the membrane of tumor cells, is very important because we know that it can be mutated, and so it means activated. And MET appears as a relevant biological parameters in that kind of type 1 papillary renal cell carcinoma, and it may play a role as well in few type 2. PRCC, as all non-clear cell, has no specific therapy available. We use by analogy with what we do with clear cell renal cell carcinoma, and the guidelines always state that patients should be referred to clinical trial so that we could try to better investigate these disease and offer new therapy and all what the clinical trial brings to the patients in terms of accessing new compounds, because the results with the available agents that are approved are quite disappointing so far.
Pros and cons. Papillary renal cell carcinoma has two main subtypes. Type 1, which is often multifocal, is characterized by papillary and tubular structure covered with small cells containing basophilic cytoplasma and small uniform oval nucleus. 3, whereas type 2, which is more heterogeneous, is characterized by papilla covered with large cells containing eosinophilic cytoplasm and large spherical nucleus with prominent nucleoli.
So in this example, why don't we focus in on the left kidney? You can see that there are cysts in both kidneys, but there is a T2 hypointense mass arising from the left kidney. It's hypointense to the adjacent renal parenchyma. Now, if you look at the post-gadolinium images, the standard post-gadolinium images are a little bit hard to interpret. Is there really enhancement within this mass, or is this lesion just intrinsically a little bit T1 hyperintense? But I think when you're evaluating renal lesions, it's these post-gadolinium subtraction images that are absolutely vital for coming down on the right diagnosis. Notice that whereas it's somewhat difficult to identify the focus of abnormal enhancement within this lesion on the standard post-gadolinium images, it is clear on the subtraction images, particularly in the venous and delayed phases, that there is peripheral nodular enhancement along the posterior margin of the mass. Now, this is an example of a papillary renal cell carcinoma. Very faint, very subtle enhancement. The enhancement tends to be greater as you go along in the later phases, venous and delayed. And often the subtraction images are going to be vital in terms of identifying that rather subtle enhancement. Now, papillary RCCs tend to have low levels of enhancement. They're often going to be T2 hypointense, and I think that MR can be a great modality for identifying these lesions. I've seen several examples where it's hard to really appreciate definite enhancement on the CT scan, but the post-gadolinium subtraction images on MR really allow you to make the right diagnosis.
Usually applied in Ecuador. Pathological review of the 161 tumors, 16 type 2 tumors, and 26 tumors that could not be classified as type 1 or type 2. The type 1 tumors were predominantly stage 1, whereas the type 2 tumors were frequently stage 3 or 4. These findings were consistent with those of previous study.
Learning medicine is hard work. Osmosis makes it easy. It takes your lectures and notes to create a personalized study plan with exclusive videos, practice questions, and flashcards, and so much more. Try it free today. Renal cell carcinomas, or RCCs, are the most common type of malignant kidney cancer in adults, generally affecting older men. Unfortunately, RCC is often considered a silent cancer because symptoms don't typically get noticed until the tumor has grown pretty large. Renal cell carcinomas form from epithelial cells in the proximal convoluted tubule of the kidney. And this is the section of the nephron that's usually located in the renal cortex, the outer rim of the kidney. The most common type of renal cell carcinoma is composed of polygonal epithelial cells, which have funny angular shapes with at least 4 sides, and are filled with clear cytoplasm full of carbohydrates and lipids. And it's those lipids that give the tumors their yellow color. At a genetic level, renal cell carcinomas have been linked to mutations on the short arm of chromosome 3, or 3p. An easy way to remember this is that RCC has 3 letters, and it's linked to chromosome 3. One of the main genes involved in renal cell carcinomas is the VHL gene, which codes for the von Hippel-Lindau tumor suppressor protein, or PVHL, which is normally expressed in all tissues. Mutations in PVHL can allow IGF-1, the type 1 insulin-like growth factor, pathway to go into overdrive. And this does 2 things. First, there's dysregulated cell growth. And second, it upregulates specific transcription factors called hypoxia-inducible factors, which in turn generate more vascular endothelial growth factor, or VEGF, as well as VEGF receptor, leading to growth of new blood vessels, or angiogenesis. Dysregulated cellular growth and angiogenesis are a recipe for tumor formation. Renal cell carcinomas can arise sporadically, or they can be part of an inherited syndrome. Sporadic tumors are usually solitary tumors in the upper pole of the kidney, and most often happen among older men that smoke cigarettes. Inherited syndromes, like von Hippel-Lindau disease, can also give rise to renal cell carcinomas. In this situation, the tumors typically affect younger men and women, and often involve both kidneys. Von Hippel-Lindau disease is a rare autosomal dominant disorder characterized by a mutation in a tumor suppressor gene, which leads to the formation of cysts and benign tumors in various parts of the body, like the eye and central nervous system. The number 1 cause of death in patients with von Hippel-Lindau disease, though, is the development of renal cell carcinomas. Individuals with renal cell carcinoma typically have one or more of the following symptoms: hematuria, or red blood cells in the urine, which is most common, a palpable mass in the abdomen or lower back, and pain in the flank or near the hip bone. Since the cancer causes a state of chronic inflammation, other classic symptoms include fever and weight loss.
Conclusion. Change in the presentation and management of RCC, as well as the fact that approximately 13% of RCC patients will die from their disease, highlight the need for additional translocation research. The integrative force of RCC have provided insight into the initiating events and early development of the disease. However, we know little about the molecular events that drive progression.
Hello, I'm going to show you how a pathologist would examine a case of renal cell carcinoma microscopically to pick up prognostically important information. So here is a very well-known protocol among pathologists from the College of American Pathologists, and this really runs through all the important factors that we need to consider when we examine a case of renal cell carcinoma. And in terms of microscopy, the histologic type is important. So I'm going to show you a case in a minute, and we can think about what histologic type it may be. The other important thing we need to look at microscopically is the histologic grade, and it goes according to the nuclear pleomorphism and the prominence of nucleoli. So let's take a look at a case. This is a low magnification view, and here is the tumor, and here is the uninvolved non-neoplastic kidney. So just to recap a little bit on your histology, this is the renal cortex because we can see the glomeruli and some of the tubules here. The more obvious ones would be the proximal convoluted tubules with the rather pink appearing epithelium. And this is the renal medulla with the collecting ducts. So moving on to the tumor, we can see that it has a very nested architecture, very well-defined nests with delicate vessels in between. And within the nests, we can see that the cells are polygonal, there is abundant clear cytoplasm, and this is filled with glycogen as well as lipid, which gives the tumor this very bright yellow golden appearance grossly. And also the cells, if you look at the nuclei, you can see that at this magnification that they're not markedly pleomorphic. So we will usually assess it, and this is roughly 10 times objective view or 100 times magnification. And what I'm going to do is to hunt for nucleoli. So if you look at this nucleus, you can just about make out the nucleolus. Similarly over here, but it is not prominent at this magnification. So first of all,